Welcome today to another edition of our lovely Grand Rounds. Today we have the pleasure of listening to one of our chief residents, Dr. Kate Degatur, to talk about childhood obesity.
Thank you, Dr. Jones. Can everybody hear me? Okay. So, hi, I'm Kate Degatur. This is my Grand Rounds, and I'm going to be discussing the childhood obesity epidemic. And so, first things first, I have nothing to disclose. Big Sugar is not paying me anything for this talk. The objectives of my lecture will be to define overweight and obesity in childhood and adolescence, to describe genetic and early childhood factors that predispose children to obesity, and describe the effectiveness of lifestyle, pharmacological, and surgical treatments available for patients with obesity. So, why this topic? Everyone's has been asking me, Kate, you're interested in allergy. Why are you talking about obesity? Because it's everywhere. All of our patients, every day when we see in clinic, I feel like we're becoming obesity and BMI blind when we see these weights in clinic. And because it's our obesity trends from the 70s to now have more than tripled. In the latest years, it had started to plateau, but depending on which studies you're seeing, between 1 in 5 to 1 in 4 school-age children are obese. These are some of the CDC national statistics. Prevalence obesity right now, they're gauging at about 18.5%. Biggest age range this affects is the 12 to 19-year-old group, and it disproportionately affects Hispanics and Black children. This is the NHANES Study. It's the National Health and Nutrition Examination Survey. They collect data in 2-year increments. This has been going on for several years. The most recent data has not yet been published. This is showing the trends in obesity based on income level, household income level, based on where they're at or above or below the federal poverty line. In recent years, they've actually even seen, for most of the trend, it's the lowest income levels are disproportionately affected with obesity, but the middle income levels are also seeing a rise. And the NHANES study also broke it down based on highest education level achieved by the head of the household. And for those who are heads of household that are high school graduate or less, we're also more affected. So, talking more about that, obesity and socioeconomic status, the middle income group has now become even more highly affected. They also broke it down based on WIC participants. WIC is the program for women and children getting supplemental nutrition. During the 2000 to 2010 range, the overall prevalence of obesity among low-income children increased from 14% to 15.5%, then 15.9%. But they did find in the 2 to 4-year-old age range, they actually had some decline in obesity. They attributed it to stronger restrictions on the amount of juice allocated and other sugary cereals. And with that, they saw from the 2010 to the 2016 range on the NHANES study that we actually decreased the national rate overall of obesity, adults and children. So moving back, how do we define obesity? So for overweight, the AAP and AMA had a 2007 combined expert committee. They defined it as BMI greater than 85th percentile, obesity as greater than the 95th percentile. The American Heart Association went ahead and further classified it for cases of severe obesity, as in BMI greater than 35 or greater than 40. And for the med students, we're basing these percentiles off of the CDC growth chart. Here you'll have your overweight category at the 85th percentile, and that'll be your obese category. And we plot this over time as kids come in for their visits, and keeping in mind the velocity of their BMI rise. What's most concerning is the ones that continue up, and we'll see direct upward trends, or that they've basically made their own curve on the line, going at a higher growth velocity. So causes. The number one, 95% of the cases of obesity will be to obesogenic lifestyle and risk factors. Only 5% count for any kind of genetic cause. They break it down into monogenic syndromes, non-syndromic monogenic obesity, and polygenic risk factors. So for your monogenic, they're referring to single gene mutations associated with like Prader-Willi, Rubinson-Tavy. These are associated with an increased release of ghrelin. There's a hormone that's normally released in response to hunger or fasting, and it stimulates increased food intake. Non-syndromic monogenic obesities, the most popular and well-researched one is leptin deficiency. A single gene mutation will cause a complete deficiency in leptin. These patients will be obese to severely obese, and the only way you can tell for this is if you get systemic leptin levels, theirs will be non-existent. If you treat them with exogenous leptin, their weight will normalize. That being said, screening for leptin is not part of your standard obesity workup. Other risk factors would be polygenic risk factors. This is through genome-wide sequencing. They have found multiple genes that on their own don't have a significant increase in obesity, but together they have an additive effect. One of the more well-studied is the FTO protein that when it's not produced properly leads to increased weight gain. And so our risk factors, first and foremost, maternal obesity and gestational diabetes has been well defined as a very big risk factor. Premature birth. We always tend to think our premature babies are small or remain small, but they have one of the higher instances of obesity later on in life. Sugar-sweetened beverages has been very well defined, as well as is sedentary lifestyle, increased screen time, lack of access to fresh food, obesogenic medications, binge eating, and the genetic syndromes like we talked about. A very big buzzword in the news media as of late has been the idea of food deserts. This refers to low-income communities without easy access to healthy and affordable food. This can be both urban areas and rural areas. Most centers define it as not having fresh, affordable food in grocery stores within a 1-mile radius, and a low instance of having access to cars. So they can't drive to get to these supermarkets. It affects approximately 23 million Americans. It's linked with poor diet, high level of obesity, and diet-related diseases. And it's really unfair to the residents, because if they actually try to get these fresh foods in their the convenience stores, very small convenience stores that are available to them, they pay between 3 to 37% higher for the same items if you got it at a suburban grocery store, supermarket. And so this is a breakdown of food deserts. Louisiana's not looking so good on this map. Even a little closer to home, you go to Google Maps. This one is the Stoner Hill Highland neighborhood. no grocery stores. We have two convenience stores. And this one's Allendale. You have nothing. And what's unfortunate for Louisiana is we have over 1 million residents that live in food deserts. That's 29% of our population. And 89% of our parishes have a food desert within them. So moving on, medications that are associated with weight gain. It's well known, we always talk about antipsychotics, but some people, or some pediatricians are less aware of our anti-epileptics that can cause weight gain. Also, many migraine medicines are associated with it. Insulin is a growth factor and can lead to weight gain. And these are other medications associated, which when you're doing your intake on patients that are obese, these are important things to know and to try to mitigate. Do they need to be on all of these antipsychotics at once if they're on multiple ones that can cause weight gain? So consequences. Unfortunately, obesity can affect your health from multiple standpoints, be it cardiovascular, metabolic, pulmonary, your liver, your musculoskeletal system, menstruation, psychosocial. So one of the most well-referenced studies was actually done in Bogalusa, Louisiana, between the 70s and 90s. They followed preschoolers, starting out with, who were obese, and found that 39% in the moderate obese category had at least 2 cardiovascular risk factors, and those were elevated LDLs, cholesterol, blood pressure, fasting blood glucose, and insulin. And 59% in the severe obesity had 2 risk factors. So our metabolic consequences, well known for us, PCOS, prediabetes, precocious puberty, and type 2 diabetes. 20 years ago, type 2 diabetes was an adult illness. You did not see this in children, or at least not often. Until 10 years ago, type 2 diabetes accounted for less than 3% of all new onset diabetes cases in kids. Now it's 45% of all new diabetes cases. And it's not just us. In Japan, over the past 20 years, they've had a 10-fold increase in type 2 diabetes among children. Pulmonary consequences. OSA has been well defined in obese children. It's characterized by intermittent or complete or partial obstruction of the airway, which can worsen your cardiovascular health. For each 1 kilogram per meter squared BMI score above the mean, your OSA risk increases 12%. So for your liver, non-alcoholic fatty liver disease, this can range from just reversible macrovascular steatosis to complete fibrosis and cirrhosis of your liver. One study showed 83% of patients undergoing bariatric surgery were found to have biopsy-proven non-alcoholic fatty liver disease. And your degree of obesity, so your levels of obesity to severe obesity, were its own independent risk factor. So the worse your obesity was, the worse your liver disease was. Well-known musculoskeletal consequences of obesity, first and foremost, SCFE. So your displacement of the femoral head from the femoral neck. Most studies have shown that your higher level of the BMI more associated with bilateral over unilateral disease. Other well-known disease would be Blount. It's a progressive varus deformity of the tibia. So here we have Blount, your varus deformity, and then SCFE. I've fallen off the ice cream cone. for those of you that are not radiology inclined like myself. And so psychosocial. Children with obesity have higher levels of low self-esteem, poor social functioning. They internalize all of their behavior when compared to their non-obese peers. They also have quality of life scores similar to patients with cancer. Their psychosocial aspects are something that you have to keep in mind when you're doing your intake on these patients. Not just asking about their activities of daily living, but also how are they doing in school? Are they getting teased? They also have poor academic performance compared to their normal weight peers. And so the AAP has an Institute for Healthy Childhood Weight. They've broken down their recommendations for treatment algorithms based on intake for patients 2 years and older. So on intake, you're assessing the behaviors, asking about their diet, and their other daily activities. Each patient, not just our obese patients, we're providing counseling on specifically diet. There are big recommendations for everyone, no matter what, every time you see them, are 5 fruits and vegetables a day, less than 2 hours of screen time per day, 1 hour or more of physical activity, zero sugary drinks every day. And this is something that in our anticipatory guidance that we should be telling our patients every well child visit, obese or not. Also, we need to be defining their weight classification. And it breaks it down into from healthy weight, overweight, and obesity, and how you should flow through the chart. So for routine care, we're providing positive reinforcement for positive behavior. If they're losing weight and they're trying, then you notice this is a time to step in and encourage them. Be positive. Our patients respond to positive input about this. And these are for our normal to overweight patients, and we're looking at their weight velocity. We don't want them to be crossing more than 2 percentiles on the growth chart, because that's a sign of increasing risk factors to get to that obese range. If you're noticing this is a time to intervene now. And we should be reassessing them at least annually. And then for our obese patients, we'll get into it. And just to reiterate, these are for our obese patients. These are the other diseases that we need to be keeping in mind and possibly screening for. Okay. So the Institute for Obesity with the AAP has broken it down to treatment stages, what they want us to go through. You advance based on their response to treatment, what their BMI is doing on your growth charts, and patient motivation. You start at the least intensive stage, you advance as needed, and it's all about empathic and empowering counseling style. And you need to keep in mind realistic and safe weight loss goals. So for children ages 2 to 5, we don't want them losing more than a pound a month. So this is a slow process. For 5 and older, you don't want them losing more than 2 pounds per week. We're trying to promote healthy and safe weight loss and sustainable. For your more severe, morbidly obese patients, you can expect a little bit faster decline in weight loss, but it's important to reassess safety, making sure they're not sticking to these fad diets that are unsafe. So our next stage would be stage 1, and this is primarily done by the PCP. These are themed visits, 15 to 20 minutes each. These aren't incredibly long. You're focusing more on behaviors that can be modified. This is positive interviewing and motivational, asking what they think they can change. Most recommend starting on 1 to 2 goals that they can meet per visit, and asking how they think they can meet it and what their barriers be. You consider linking in with a dietitian if one's available, social work, physical therapy. So your goals are the positive behavior changes regardless of their change in BMI. And you're monitoring their weight maintenance and hoping for at least a decrease in their BMI velocity so they don't continue to climb the mountain on that growth chart. Follow-up, you kind of have to base it on family and patient motivation. You want to try to meet with them at least monthly. If by 3 to 6 months you do not see any improvement, you move on to stage 2, the structured weight management. This is also done strictly with the PCP. It's more intense support and follow-up. This is you calling and keeping up with the patient, asking how they're doing this week. You can even ask for food charts, keeping food diaries, and activity level diaries. For our older patients, it's a lot easier to for them to track it on their smartphones, because everyone has one now. There's multiple apps that you can track with. For this, you're following up every 2 to 4 weeks, a little more intense. And again, after 3 to 6 months, if you're not seeing any changes, you move to the next stage, which is the comprehensive multidisciplinary intervention. This is when we're calling in or referring to a pediatric weight management clinic or a multidisciplinary team, like Dr. Mondehaven's clinic that we have here. It's increased intensity of behavior changes, frequency of visits, and specialists. They're meeting with dietitians at this stage, keeping food logs, sending their food logs and their activity logs to the weight management clinic, and more. Some even go to weekly weigh-ins. Again, we're focusing on for positive behavior changes and weight maintenance. And again, if you're still not improving with this, you go to the most intense stage, would be tertiary care intervention. Again, this is chiefly managed by a weight management clinic, but with the goals of getting to pharmacotherapy and bariatric surgery. And from there, we'll go to lifestyle modification. So we base it on diet, physical activity, sleep and behavior, and then any kind of pharmacological therapy. Pharmacology is both trying to limit the obesogenic medications that they may be taking, and also maybe trying to add something to their regimen that can decrease their weight. So the next few slides are from the Obesity Medicine Association. They had a lovely table at the AAP conference, and they were very friendly. So starting at 0 to 24 months, these are their recommendations. These are what you're telling your patients and your parents when they come in. So absolutely no screen time. I know many of us have seen patients come into clinic and they're holding mom's phone. They may be having their own tablet by 2 years old. So absolutely no screen time is recommended. Kids need to play. No TV in the bedrooms. Allow the infant to feed themselves. Don't force your picky 2-year-old to finish their plate. And they need proper sleep. They also recommend exclusive breastfeeding for the first 6 to 12 months, and not starting complementary foods until 6 months. Early introduction of foods is also an independent risk factor for obesity later on in life. Absolutely no juice. Kids don't need juice. No fast food, no dessert, and let them play. Let them play on the floor, have a playpen. They need to move around. Moving on to our 5 to 9-year-old category. This is when usually we're going to assess for your more obesogenic medications and treating comorbid conditions like asthma. If they can finally breathe and cannot wheeze and actually run around, that's a good thing, and actually get to exercise. At this age, you want to limit screen time between hopefully less than 1 hour, but definitely less than 2 hours per day. They need an actual bedtime, sleeping between 11 to 14 hours per night. This is the age where you need to really reinforce eating together as a family, not in front of the TV, computer screen. Kids that eat in front of a computer in front of the TV will eat 1.5 to 3 times more food eating absent-mindedly. This is also when you need to really reinforce with the parent that healthy lifestyle, because this is the age that parrots everything their parents do. So if a parent is sitting on the couch watching TV all day, eating fast food, why would the 5-year-old do anything different? This is when you really need to break down how many servings of proteins, dairy, vegetables a day. Still no juice or sugary beverages. And also reinforcing portion control. And one of the biggest takeaways is activity level. Kids of this age need 60 minutes or more of vigorous activity a day. Also important to note, this does not have to be all in one setting. You can have 15-minute increments, so recess and other things, but they do need active play. So your 10 to 14 range, this is when you can start introducing more pharmacotherapy, or when it's actually FDA approved. We'll discuss that in a later slide. Other than that, everything is the same. Reinforcing screen time rules, bedtimes, and proper diet. And this is the age when we need to start stressing decreasing non-academic sedentary time. So we understand you're going to be sedentary during the school day to a certain extent, that once they get home, they need to be moving. They don't need to be binge watching Netflix for 5 hours once they get home. So the 15 to 18 age range, more pharmacotherapy gets introduced, and other than that, this age range needs 60 to 90 minutes a day. So even more of actual physical activity. And so breaking down into diet, these are, I'm not going to read the whole slide for y'all, but this is the breakdown of what they should actually be eating if your parents are asking you, and like myself, you're not a nutrition expert. For what's the biggest takeaways from these recommendations that I've found were, one, for vegetables, they really were stressing these are actual both green leafy vegetables, but completely excluding potatoes, corn, and other starches, because they do not count for these servings. The other big takeaway would be your fats and oils. Those are your recommendations per day. So can anyone see why fast food will set you way over the limit? And just for a breakdown, these are, the next few slides are going to show you WIC approved foods. What I wanted to highlight was on the next slide. So for kids, for the month, they are allotted 64 ounces of juice. It's a lot of juice per month, with a really high sugar content. And just for a break from the general slides, I was going to show, not that. This was a slide deck prepared to just try to show people how much sugar is actually in drinks that we get every day. So your Coke, not the biggest surprise, but your Pepsi, not a Pepsi fan, but your apple juice. It's not the healthiest option. Your Sunny D, and that's a much smaller portion size, but still a lot of sugar. Your green tea, your sweet tea, Red Bull. That's a pile of cereal. I couldn't tell what it was at first. Monster. Milk, skim milk. And there's one more that I think I'll hit home for. This one was a surprise. Those actually have 250 calories. For all of us coffee lovers. And one more. So, when parents ask you, Doc, how am I supposed to get my 5-year-old to exercise? This is what we're talking about. As simple as running around outside, playing hopscotch, jumping rope, hula hooping. These are all activities that can help burn energy and burn calories. We're not asking for your patient to go pump iron in the gym. So keep in mind age appropriate, and that these can be in 15-minute increments. This doesn't have to be prolonged, because but also keeping in mind extended periods of inactivity are really highly discouraged. And for adolescents, this is a little bit easier. They can join sports. They can be in dance classes. They can a lot of them have Wii Fits. They also, a large portion of them have smartphones, and they can track their progress and can share with you. So next big area of study has been school-based interventions. Idea behind this is you have a captive audience. They're there 8 hours a day. You have relative control over their diet, unless parents choose to opt out of school-based food, and you can provide physical education. This was a systematic review in 2006 of 11 different studies. I'm not going to go through every one, but one of the interesting ones was the Stanford GEM study. This was done in 2nd and 4th graders. And their two biggest interventions, which I thought were fun, were an after-school dance class, 5 days a week for 3 months, and home intervention where they went in the home and educated and tried to reduce TV time. And that was 5 different lessons. They actually had really awesome results. They lowered their BMI, their physical activity increased, they reduced their TV watching time by almost 5 hours per week, and their grades improved as well. Next study that I thought was interesting was the Project Spark, where this was in Stanford. This was a little more intensive. They had PE specialists come in, and compared to their standard PE educators, come and teach 3 days a week for 36 weeks. They also brought in programs about food, screen time, and they actually had improvement in girls' obesity in that study, and increased their physical activity time. So, and back to that one, there are also caveats with school-based intervention. I think we're all pretty aware of when the Obama administration came out with the new food program for schools. 2 million children were taken out of enrollment for school-based foods after that one because they wouldn't tolerate the food there. So it's mostly attributed to schools didn't have enough money to actually meet these dietary standards, and so the food was substandard. So there is a lack of funding in this department, this section of it. Moving on to pharmacotherapy, only 3 drugs have actually been FDA approved for weight loss in children. First one was sibutramine. It's a monoamine reuptake inhibitor. It reduces the reuptake of norepinephrine, serotonin, and dopamine, which enhance satiety. It actually worked decently, but then had to be pulled from the market in 2010 because of sudden death and other cardiovascular risk. Next one is orlistat, which is an over-the-counter medication commonly marketed as Ally. It's a lipase inhibitor that blocks the absorption of fat. It's approved for children greater than 12. Mild to moderate actual weight loss with this one, mostly due to compliance because of its side effects. Fecal leakage, diarrhea, fatty runny stools, and abdominal pain. So, most 12-year-olds don't want that happening to them at school. I understand. Next medicine, metformin. This has been used off-label for weight loss because they've noticed in type 2 diabetics that they've seen a 1.38 kilogram per meter squared weight loss, BMI reduction when used over 6 to 12 months. But this isn't approved. Next one would be Exenatide, another diabetic medication that's seen moderate weight loss as well. Another drug that is FDA approved is Phentermine, marketed as Adipex. This is a scheduled drug. It's a substituted amphetamine. It promotes increased release of dopamine, norepinephrine, and serotonin, which reduces your hunger perception. So just like our patients on ADHD medications have noticed a decrease in appetite, this is the same logic. It's approved for children 16 or greater for weight loss, and they've seen small to moderate effects on this. And side effects are anxiety, tremors, increased blood pressure. These medications are meant to be used over a short period of time, usually 1 to 2 months, though they have seen some studies have taken it to the 6-month mark with sustained weight loss. Finally, topiramate. There's multiple studies going on now because they've noticed in their epileptic patients a decrease in food craving. But like I said, this is not FDA approved. Going back for bariatric surgery. So this is basically our nuclear option. This is when we've exhausted all other options. It is actually approved for adolescents. So this is 12 and up with BMI greater than 40 and mild comorbidities, or a BMI greater than 35 and significant comorbidities. So the mild ones that they're talking about are your dyslipidemias, your high blood pressure, urinary incontinence, mild OSA. Your severe ones would be type 2 diabetes, severe OSA, and pseudotumor cerebri. Medicaid actually does pay for bariatric surgery in patients greater than 12, but their caveat is your BMI has to be greater than 40. Additional criteria for this would be skeletal maturity. You have to be Tanner stage 4 or 5 and have closure of the epiphysis on bone age studies. You have to have psychosocial stability. So these patients are assessed by therapists who assess that they're ready for this, because this is a very intensive process and life-changing. They need to have easy access to follow-up care. For obvious reasons, they can't be living out in the boonies and have, in case something happens, they have to be close and have easy access. They have to show the ability to adhere to a healthy lifestyle. Most bariatric centers have them follow a diet and exercise regimen for at least 6 months before they'll even consider going to surgery. They have to have a reliable caregiver. These are minors. They need help. They're going to need help getting to appointments and post-surgery. So classic bariatric surgery would be the Roux. It is approved for patients less than 18. It is both a restrictive and malabsorptive process because it basically divides your stomach into 2 smaller pouches and connects directly to the jejunum, bypassing your duodenum. It has shown pretty good weight reduction in the severely obese category. These patients are on dietary supplements for life after due to vitamin deficiencies. Your fat associated. Sorry. Next one would be your laparoscopic adjustable gastric band, or just the gastric band, it's commonly known. It's technically less invasive. though it is not FDA approved for patients less than 18, though there are ongoing studies in the adolescent age group that have shown pretty good weight loss. What they do is they go in laparoscopically, put a band above around the top portion of your stomach, and bury an access port subcutaneously, usually around your diaphragm. And through that, they inject saline, which the more saline they inject, the tighter the ring around your stomach. So they can do that, put more in and take more out to gauge to control your satiety. And over a series of visits, you go in and readjust. So the next and final one is your vertical sleeve gastrectomy. It's becoming really popular because the idea is you're not implanting anything foreign and you're not manipulating your intestines. But this one's a little more intense. It excises about 80% of your stomach, but it has shown pretty good weight loss in over a 2-year period in pediatric patients. So where do we go from here? As primary care physicians, what are we doing every day in our clinics? We have a very finite amount of time, and so what are strategies that we can have in our back pocket for every day? First and foremost, pay attention to the BMI. Don't be nose blind. I've picked up patients that for the past 5 visits, their BMI has stayed in the above 99 percentile, just that solid line at the top of the screen, and no one's ever addressed it. We need to give anticipatory guidance, not even for our normal weight kids. Starting day 1, nursery visits, we need to be thinking about obesity prevention. We need to promote breastfeeding. Delay starting complementary foods until at least 6 months. No sugary beverages, no juice. Just say no to it. Take it away from them. No fast food. Limit your screen time. Make sure they're sleeping. And talk about a healthy diet and be specific. Our patients need specifics, breakdown. Get a food journal for them. What are they eating every day? And usually most parents, once they see it added up, they realize, oh my goodness, we're definitely overfeeding and undernourishing our kids because we're giving them empty calories. And finally, reducing our sedentary time and letting our patients be active. Like I said, the AAP's obesity algorithm is a great tool to follow and can be used. And finally, screen for your comorbid conditions and follow up regularly. And those are my resources. I didn't realize they're so tiny. Any questions, guys?